mesoderm, this is known as your lateral plate of your mesoderm, right? This is going to like wrap around like that. Okay, let me just draw it. Okay, your ectoderm, your mesoderm, and your endoderm. Okay, so this is your cranial end and caudal end. So it would like just wrap around, this mesoderm is going to wrap around and it's going to form a hollow like structure, and this hollow structure is going to result into your mature alimentary canal, right? So this mesoderm, the lateral part of your mesoderm, you guys must remember that it's going to like make the future mesentery of your GIT. Do you guys know what is mesentery?
Yes,
Yes.
which is the connective tissue, which is connecting all the small intestine, everything, and which is allow the blood vessels through this, like the branches of the superior mesenteric artery and the inferior mesenteric artery.
Okay, so it's a kind of connective tissue which is like connecting. It's like connected to all of your alimentary canal, and basically the nerve supply of your alimentary canal passes to this mesentery, right? So you can simply think of that the blood supply to your alimentary canal is just provided by your mesentery, right? So what happens that you are going to see closure of this. Uh, like these three discs are going to wrap on, then they're going to close. But another thing which you guys must remember, that your mid gut, right? You have like three portions: your foregut, your mid gut, and your hand gut. We'll be discussing that what's the difference, like from which area to which area you have your foregut. That we'll be discussing in anatomy portion. But one thing which you guys must remember, that your mid gut. Okay, can you guys tell me that what structure are included in your mid gut? Hello.
Duodenum, jejunum, and ileum.
Okay, from the duodenum, starting towards like your small intestine, your cecum, till two-third of your transverse colon, right? This is your midgut basically, right? So your midgut basically what happens, like it's, you can simply think of it's a, like a long, a big alimentary canal circuit. So it is basically formed outside of your body. Like what happens at the 6th week, at the 6th week of development, what happens, your midgut is going to come out like that outside, and it's basically covered by a peritoneum, right? So it would be made outside of your body, coming through your umbilical cord, that like you can see that the umbilicus, right? So through this area in the 6th week of development is going to come out, right? And it's going to develop there. What happens in the 10th week, like in the 6th week, it's going to come out, it's going to develop outside your body, right? So at the 10th week, then it's going to return back into your abdomen, right? And okay, so at 10th week, it's going to return back to your abdomen, right? And what happens, there is an important process which you guys must remember, that your mid gut, after entering to your abdominal cavity, it have to rotate anti-clockwise to 70 degree. It's very important point, to 70 degree anti-clockwise, right? Once it enter back into your um, abdominal cavity. Why is that necessary? Like this 270-degree anti-clockwise rotation is like very important for your midgut, because in order to attain the proper place like inside your abdomen, it have to undergo this 270-degree rotation. For example, if you have some problems with this rotation, and you are going to see, like for example, if someone is having mal rotation, what happens, as you guys know, that mesentery is going to supply your midgut as well, right? So what happens if there is any problem with this 270-degree rotation? What happens that your blood vessels can be disrupted, right? What happens, like there is a condition which is known as volvulus. What happens in volvulus, like simply they can go, they can wrap around your blood vessels, and as a result of that, it can result into ischemia of your midgut. So this 270-degree rotation is very much important. You guys are going to see an MCQs in UWorld, like basically they will be giving you a picture in which you are going to see the midgut on the right side, right? So like for example, if you have normally the midgut have to, like, okay, let me just draw the rough structure. For example, this is your colon, right? So midgut have to sit here, right? So sometimes what happens, due to this malrotation, it can just be present, let's suppose, on the right side. So this indicates basically the malrotation of your midgut. Although it had entered your abdominal cavity, like we have certain pathologies in which this midgut do not even enter back into the abdominal cavity. Okay, guys, you just tell me about those pathology. For example, if the midgut remain here and does not enter, what's that pathology called?
Omphalocele.
Omphalocele. Okay, perfect. It's omphalocele. Okay, and you have another pathology as well. For example, if the midgut like move from right side to your umbilicus, for example, if it tears your abdominal muscles and it came out right side, like for example, this is your umbilicus, right? And on the right side, if you are seeing a lot of midgut coming out, what's that condition called?
Gastroschisis.
Gastration.
Gastroschisis. We'll be discussing it in the next slide. But remember, guys, 270-degree anti-clockwise rotation is very important in order to have their proper location. If we have any malrotation, it can disrupt the blood supply, which can lead to ischemia. Simple, right? Okay. Then you guys know that you have your nervous system of your alimentary canal. What's that called? That's called enteric nervous system, right? And it's like it have a lot of neurons there, like the enteric nervous system. So, can you just guys tell me that enteric nervous system is derivative of which cells?
Neural crest.
Okay, so it's basically due to it's made up of your neural crest cells, right? They're going to migrate and they're going to result into enteric nervous system, right? So then what happens? Let's discuss the gut section. You have your foregut, right? Your midgut and your hindgut. So anyone who can tell me that foregut starts from your mouth till, yes?
Duodenum.
First part of the duodenum.
Okay, first part.
Second part of duodenum.
First or second? Yes.
I think second. Ampulla of Vater.
Okay, it's still ampulla of Vater, right? Okay, but midgut starts from like ampulla, beyond the ampulla of Vater, from the duodenum till, yes.
Third of the transverse colon.
Proximal
Okay,
transverse.
2/3 of your transverse colon, right? Like all of your small intestine, then your cecum, ascending colon, and 2/3 of your transverse colon, right? And hindgut.
1/3 of the transverse
This is
colon.
1/3 of the transverse
Okay,
colon.
the remaining 1/3 of transverse till
Pectinate line.
perfect pectinate line of anal canal, right? Okay, we'll be discussing that what is pectinate line and everything. Okay, so it's also differentiated on the basis of blood supply as well. Like, can you guys tell me that the foregut is supplied by, yes,
Celiac trunk.
Celiac trunk.
celiac trunk. Okay, what's the blood supply of your midgut?
Superior
Superior
mesenteric
mesenteric artery.
Perfect. What's the blood supply of your hindgut?
inferior mesenteric artery.
Okay, perfect. So now let's discuss the fold closure. Like as I have already told you that here all of your 3 layers are going to fold and ultimately they are going to close there, right? So for example, like you have your lateral folds. You can simply remember that you have your cranial fold, your rostral fold, like caudal, the back fold, and cranial. Like, okay, let me just give you an example. For example, you have your lateral folds, right? Once the lateral fold fuses together, it's going to close off. Okay, you guys know that your midgut is going to come out here. Once the lateral fold close, it's going to return back. It's going to rotate 270-degree and it's going to close off. Simple. It's a normal process. For example, if this lateral fold do not closes, so we are going to see some conditions, right? That is omphalocele, which you guys have already told me, omphalocele, and gastroschisis as well. Okay, so now let's discuss omphalocele. Can you guys tell me what is omphalocele?
Herniation of abdominal content through umbilicus.
Okay, what if I say that it's a persistent herniation? Like, what do I mean by persistent herniation? That you already, the herniation, the midgut coming out is common in all individuals, but it persists in case of omphalocele, right? It do not enter back. Can I say that? Hello?
Yeah.
Yes. So basically, it's persistent herniation. Okay, the herniation which is like common in all individual, it's going to persist in this case. In omphalocele, it's going to persist. Okay, so you are going to see. Okay, what next about omphalocele? That it's going to be covered by peritoneal lining, right? Right? It's going to be covered by peritoneal lining. Okay, important thing. For example, if I have covering the peritoneal line covering, so what do you think will happen to alpha fetoprotein? Would it be elevated or would it be normal in most cases?
Normal?
Yes, it's going to be normal in most cases, right? It won't be elevated. Simply you can think of that you have peritoneum that is surrounding your midgut content. So it won't leave your alpha fetoprotein to leak into the amniotic fluid and then into maternal serum, right? Okay. So it's basically associated with trisomy 18, 13, okay? Then you have your gastroschisis. Okay, so gastroschisis is basically herniation through, yes,
Wall defect?
it's like not straight into the umbilicus part, right? It's going to be always at the right side of your umbilicus, right? Hello? It's also the herniation of your midgut, of midgut. Like simply you can think of that this was the first omphalocele which we have discussed. It's basically the persistent herniation, right? But in case of gastroschisis, so simply you can think of that the gut content is going to move like this is your umbilicus. It's going to move like from the right side. You'll be seeing herniation of the gut content, right? And another thing, it won't be covered by your peritoneum.
Peritoneum.
Yes, perfect. So, like it's a basically surgical emergency. You have to treat them directly, like via surgery. You have to like re-enter all of these content back into the abdomen because like you have increased chances of dehydration as well. For example, if it isn't covered with your peritoneum, right? So it's going to become dry. It's going to become dehydrated, right? So it's a surgical emergency. Okay, another thing. Now we do not have any covering. So what would happen to the level of alpha fetoprotein in case of gastroschisis? Yes.
Increase.
Elevated?
Yes, it's going to be elevated. Okay. Then we have a similar kind of pathology as associated with content coming out of your umbilicus. That is umbilical hernia. Can you guys tell me what is umbilical hernia?
Umbilical ring does not close?
Perfect. So basically, you have an umbilical ring. For example, if this ring do not close, you're going to see this MCQ in Google, right? If this ring do not close, what happens? You are going to see content coming out of your umbilicus, but this time it would be covered by your skin, right? Hello?
Yeah.
It's covered by skin and it's like easily reducible. Like for example, if you push the contents, it can simply enter into your abdominal cavity, right? So, okay, it's basically associated with your Down syndrome and hypothyroidism. Hypothyroidism. You guys might have seen in the MCQs while you guys were doing hypothyroidism. Hypothyroidism may be associated with umbilical hernia. So this is your MCQs. It's due to incomplete closure of your umbilical ring, right? Which leads to umbilical hernia. Okay. So can you guys just give me an quick overview over these three topics so that we can just move forward? Hello. Hello. Dr. Zainab, please, can you just give us a quick overview?
Okay. If the lateral fold does not close, we will have pathology which is known as omphalocele and gastroschisis. In omphalocele, the midgut which normally herniates during the 6th week, it persists, does not come, and it's covered by peritoneum. And
Yes.
alpha fetoprotein would be normal in this condition because it is
Normal,
covered by
yeah.
peritoneum. And
Okay.
in it's associated with chromosomal abnormalities like 13, trisomy 18.
Yes.
And in gastroschisis, there is the abdominal contents herniates through abdominal wall defect, and it's usually on the right of the umbilicus.
Yes. Perfect.
It is not covered by peritoneum. It is not associated with chromosomal abnormalities, and
Okay.
there is increased chance of dehydrations, and alpha fetoprotein would be elevated.
Yes.
In congenital umbilical hernia, there is failure of umbilical ring to close.
Yes. So
It
what
is
happens
covered
in
by
this case? What
skin,
would be the presenting features?
like this is associated with Down syndrome and congenital hypothyroidism,
Okay. Perfect.
and this protrudes when there is increased intra-abdominal pressures, like when
Yes.
you are
Like
carving.
it's going to, yes. Perfect. So whenever the intra-abdominal pressure increases, you're going to see herniation or protrusion of these structure via umbilicus. But important point, it would be covered by your Skin.
Skin.
Okay. So the next thing which we are going to discuss is tracheoesophageal defects. You guys are going to see a lot of MCQs, right? Like these are very high yield topics. Okay. Tracheoesophageal defects. So the first, which is like the most normal, like basically you can have three types of tracheoesophageal fistulas or connection. Can you guys tell me that what is the fistula? What's the general term fistula used for?
Abnormal connection between two hollow tubes.
Abnormal connection between two tubes. Okay, simple. So, for example, the most common tracheoesophageal defect is basically your esophageal atresia, esophageal atresia with distal tracheoesophageal fistula. As the name indicates, what's atresia? Atresia is simply, for example, if a tube is like ending blindly, if you have a blind tube, for example, what happens to the proximal part of your esophagus? It's going to be a blind tube. Simple. And as the name indicates, distal tracheoesophageal fistula. You guys know in the pulmonary section we just discussed that normally your lungs, like all of your respiratory system arises from your foregut, right? Like for example, this is your foregut. You are going to see a diverticulum arising, that is known as respiratory diverticulum. Then what happens to the respiratory diverticulum? You're going to see certain phases. If you guys remember, every surgeon can see alveoli, right? Earlier pulmonologists can see alveoli, embryonic state, pulmonic extension, oblique, right? So then you're going to see like complete development of your lungs. So the basic concept is that your lung system arises from your foregut, right? So sometimes what happens, you can have abnormal connection between your lungs or your trachea or your also and your esophagus, because the origin is same. Both are like your foregut, right? So what happens in esophageal atresia with distal tracheoesophageal? It's the most common condition, which is basically 95%, right? So you're going to see atretic or blind, the proximal part of your esophagus is going to result into a blind pouch. And what happens to your distal portion? It's going to be connected to your, yes, okay, connected to your trachea. For example, this trachea, right? Okay, let me just draw this thing. So this means that the proximal part is blind tube, and the distal is basically having fistula or abnormal connection between your distal esophagus and your trachea. So what would be the complication scenes? They're very easy. You guys know what's the basically your amniotic fluid. Amniotic fluid is basically your fetal urine, right?
Yeah.
It have to be swallowed in order to recycle it. Okay, so it's basically swallowed, right, by your fetus. So for example, if I have this blind tube, it means now the fetus cannot swallow, it cannot enter all of the amniotic fluid into digestive tract in order to have this complete cycle, right? So what happens, you're going to see a condition that is polyhydramnios, right? Hello?
Yes, Dr. Kamal.
Okay, just give me a second. Okay, so what happens that you're going to see accumulation of all of your amniotic fluid, giving you a condition that is known as polyhydramnios, right? Is that right?
Yes.
Hello?
Yeah.
Okay. Another thing, for example, if this baby, let's suppose, is eating something, so it cannot enter your stomach, so he would just vomit that, right? So you're going to see vomiting as well. Is that right?
Yes,
Hello?
vomiting after first
Yes.
eating.
Yes, vomiting after first eating. Similarly, you are going to see drooling of saliva as well. Drooling of saliva, like all of the salivary content is going to move out of your mouth, and you're going to see extreme drooling, right? And you cannot pass NG tube, right?
Yes.
Nasogastric tube,
Yeah.
because this tube never connects with your esophagus. But sometimes what happens, like as you know, the distal part is connected to your trachea. So either the gas can enter your stomach, or either the stomach content can enter your trachea and your lungs. It's simple, right? You can see it. So either what happens, you can see entry of, let's suppose in this case, HCl into your lungs or entry of air into your stomach. So what would we be seeing? We are going to see distended stomach because the air is going to enter your stomach. Secondly, we can also see pneumonia, that is aspiration pneumonia as well. For example, if the HCl is constantly moving into your lungs, so it can give you aspiration pneumonia, right?
Yeah.
Okay, so this was all about. Okay, you are going to see a lot of MCQs on this condition, like esophageal atresia with distal tracheoesophageal fistula. Sometimes what happens? Yes,
Dr. Ahmad, sorry, quick question. Why is it associated with cystic fibrosis?
it's associated with
Cystic fibrosis.
cystic fibrosis.
Why? I'm confused with that.
Okay, so simply you can think of like what happens in cystic fibrosis. Like it's basically a pathology of your lungs, right?
Yeah.
Okay, so in cystic fibrosis, simply you can think of like you can just make a concept in a way that, for example, if you have a lot of mucus plugging within your lungs, right?
Mm-hmm.
And so there you are going to see a lot of pathologies associated with your lungs, right? Like basically, I do not know the exact association, but simply if you want to remember it, so you can think of that. Like if you have pathology in your lungs, right? And cystic
Mm-hmm.
fibrosis is basically a genetic condition, right?
Okay.
And both of them come like are made up of your foregut, right? Like
Yeah.
both your lungs and your trachea, for like both your of your alimentary canal and your trachea or your lungs come out from a single thing. That is your foregut, right?
Okay.
Okay, so you have genetic predisposition to cystic fibrosis. It means something is wrong in those on the genetic level, on the chromosomal level, in those cells which are going to give rise to both of your alimentary canal and your lungs, right? So they can have this intermixed pathology as well because, like, simply you can think of both of the same, both of them are derivatives of single foregut, right? And you have pathology like a chromosomal abnormalities or anomalies in the cells of your foregut. So there is more likely to have certain condition in which both of these things are intermixed. Simply you can think of. I would just find the exact reason. I'll just tell you. But till now you can just simply think of like that, right?
Thank you, Dr. Ahmad.
Okay. So a second. Okay. So anyone who can just give us a quick overview of esophageal atresia with distal esophageal fistula. Hello. Hello.
So esophageal atresia is actually very common, and it comes with polyhydramnions in utero, and
Okay.
it's because of inability for the fetus to swallow the amniotic fluid.
Okay.
And the diagnosis is it's failure to nasogastric tube to enter into the stomach.
Okay.
And the first thing you can see in a child is they vomit first, the first feeding, without the greenish liquid.
Okay.
And atresial, there are a few types of atresial. One is the
Okay. Okay. So if we are having distal fistula in this case, so what would happen as we discussed? There are increased chances of which things? Here, if you have connection, so it means that things can enter your lung.
Respiration,
Oh yes, perfect. Aspiration.
respiratory pneumonia,
Yes, aspiration pneumonia.
distension, yes,
Yes.
distension of the stomach.
Yes, distension of stomach. Okay.
So,
let
doctor, exact diagnosis, it's by X-ray with contrast substances, right? Or in the tube is enough.
yes, if the tube isn't passing and if the tube still remain in the thoracic cavity, right? And like it would just, for example, if this is the blind tube, right? And if you are inserting the angio tube, so on the X-rays you are going to see this tube like inverted back, right? So it would never enter your stomach. So you can simply diagnose it in this way as well, right?
So no need the contrast substances, yes?
No, contrast substances are basically used in the further pathologies which we'll be discussing. For example, if you have achalasia, right? So in those conditions, you are going to see contrast. You are going to see use contrast for the diagnosis, right? Okay. Okay, so there is a there is another type of this tracheoesophageal defect, which is basically known as pure esophageal atresia. As the name indicate, your esophagus here is atretic. Okay, and this is, let's suppose, your trachea, right? I'm just drawing the cartilaginous rings. So for this is no, this is basically your pure esophageal atretic variant, right? So you have pure esophagus is purely atretic with no distal connection with your, no distal part isn't connected with your trachea. This is basically your pure form. So there can be certain causes of pure esophageal atresia. Like the one cause can be, for example, if the blood vessel, let's suppose if you have a blood supply to esophagus, this part of esophagus, for example, if it is disrupted, it would lead to necrosis of this part, right? Which I'm drawing here. So if it leads to necrosis, you know, inflammatory substances are going to eat it off, and ultimately you are going to see atresia, right? This can be one reason of pure esophageal atresia, right? For example, if the blood supply to certain portion of your esophagus is disrupted, it would lead to pure, yes, pure atresia, right? Hello? Can you guys hear me?
Yes, sir, we can hear you.
Okay. Another thing, you know that normally inside our body, all of the tubular system was first a solid tube, right? All of the tubes inside your body initially were solid tubes. Then happens a phenomena which is known as canalizations. Like canals are going to be formed in between them, right? Like you're going to see apoptosis of all of these solid tubes, and you're going to see canalization, and as a result of that, you'll be seeing this lumen made in between it. So this process is basically known as canalization. Second reason of this pure esophageal atresia could be, for example, if the canalization do not take place here, it can also lead to pure esophageal atresia, right? Is that right?
Yeah.
Okay. So the third variant of tracheoesophageal defect is H type, or pure tracheoesophageal fistula. Pure tracheoesophageal fistula, or H type. As the name indicates, you are going to see H type. This is your H type. Like what happens in this condition, your esophagus is still connected with your stomach, but you have an extra fistula which is connecting your alimentary canal with your respiratory system or your trachea, right? So in this condition, you are going to see increased risk of aspiration pneumonia, right? But can we see polyhydramnios in this condition?
I don't think so.
No.
No.
Who said yes? Hello? Okay. So it means that the fetus can simply swallow it. It can enter into your stomach, and ultimately it can just follow the path. But one important complication which can happen is that you might see some aspiration of some of the amniotic fluid entering your trachea, right? And it could lead to aspiration pneumonia, right? Hello? Okay. So the pure tracheoesophageal fistula is basically related with your potential risk for aspiration pneumonia, and secondly, you can also see gaseous content. It can enter the stomach as well. So you're going to see prominent gastric bubble in this, but you won't be seeing polyhydramnios in case of pure tracheoesophageal fistula. Okay. So another thing which we are going to discuss is intestinal atresia. Okay, intestinal atresia. So what is intestinal atresia? Can you guys just tell me? As the name indicates, it's straightforward.
Yeah, just some part of the intestines get blocked or cut off.
Okay, some part of the intestine is going to be blocked. Okay, for example, if I am blocking off the duodenum, let's suppose this is my duodenum, right? And you have all of your things that's draining into the duodenum. For example, as we have already discussed that we have, first of all, in the early development, all of the things, all of the tubular system inside our body were a solid tube. Then happens the process of canalization. For example, this is your duodenum, and this part of your duodenum do not recanalize. it means you're going to see blockage of this part, right? Or atresia or a blind tube. Duodenum ending into a blind tube because you haven't recanalizes this part, right? So in this case, you're going to see it's an intestinal atresia, right? Hello?
Yes, doctor.
Okay. So if I have intestinal, if for example, if someone is having intestinal atresia, so he would be having some associative things as well, or associative finding. Can you guys tell me? We have already discussed most of them. Will we be seeing polyhydramnios in these individuals?
Um, I think yeah.
Yes, we are going to see polyhydramnios. For example, now, for example, if the fetus is swallowing, it can enter the stomach and first part of duodenum. It isn't still reabsorbed completely. Stomach cannot reabsorb things. So you'll be seeing polyhydramnios, right? Okay. Another thing, we will be seeing vomiting as well. If I'm just disrupting this part and I'm just seeing food being accumulated here, and these are your muscular structures, so it can just give you vomiting, right? But that vomiting would be special. It would be also having mixture from your, yes, liver, right? You're also going to see bile in that vomit because the closure point or the atretic point is beyond the ampulla of Vater or beyond the substance. Like, for example, all of the content in the duodenum, you guys know that your pancreatic content and your content from your liver are going to drain into your duodenum, right?
Yep.
So basically what happens, the atretic part is beyond that drainage. So it means that now, for example, if I'm accumulating food, so the bile is also going to be present in that vomit. So you're going to see bilious vomiting. Simple. Is that right?
Yes, doctor.
Yeah.
Okay. For example, if I have this part atretic, so what happens? All of the things beyond this atresia are going to dilate, right? Like that, because you're going to see distension on this part. Food is going to accumulate, and the part which is beyond, it's also going to dilate, right?
Yeah.
Okay. So you will be seeing a finding which is known as double bubble appearance. Double bubble in case of duodenal atresia, right? And it's basically associated with your Down syndrome. Okay, so simply you can just remind it of 3Ds. Okay, duodenal atresia, double bubble, and Down syndrome, right?
Yes, doctor.
Okay, so we are going to see polyhydramnios, bilious vomiting, and abdominal distension. That's simple, right? Okay, so now really important one, you are going to see a lot of MCQs in UWorld as well as on your NBMEs as well. That is your pyloric stenosis. Pyloric stenosis. So can anyone just tell me what is pyloric stenosis?
The pylorus or the stomach hypertrophy.
Okay. For
Obstruction.
example, this is your stomach, this is your fundus, your body, your antrum, and your pylorus, right? This is your pylorus from which the food is going to enter into your duodenum, right? So sometimes what happens that this valve, right? It's sometimes what happens, it's going to hypertrophy, right? And as a result of that, it's going to close this part of your stomach, right? Hello?
Yes, doctor.
Okay. So if it's hypertrophic and it's closing this part, so what happens? On physical examination, you are going to see a hard structure, olive-like structure. So olive-like structure basically indicates pyloric stenosis, right? For example, if I'm palpating, like for example, your abdomen, and I see like an olive-like mass, it would be more suggestive of pyloric stenosis, right? Another thing, if I'm stenosing this part, so again, you're going to see content building up here in the stomach, right? And stomach is a muscular organ. It's going to force all of this food and you're going to see vomiting. But this time, the vomiting would be projectile, right? You're going to see projectile vomiting in case of pyloric stenosis. Is that right?
Yes, doctor.
Yeah.
Okay. There is a mnemonic that is PM. Okay, it's Prime Minister, right? PM. So let me add another M. So PMM. Pyloric stenosis, mainly you are going to see in males, right? Male, okay, firstborn male, and it's basically due to macrolide use as well. For example, if the mother is using a lot of macrolides, you know what are macrolides? 50S inhibitors, erythromycin, azithromycin, right? Thro, whenever you say thromycin word, so it indicates your macrolides, right?
Yep.
Okay, so PMM, pyloric stenosis in firstborn male, and for example, if the mother is using macrolides, right? So you are going to see an olive-like mass. You are going to see vomiting. That would be projectile vomiting. Why? All of the content is building here. The muscular organ, that is your stomach, is going to push all of the content back, antiperistalsis, and you are going to see. Okay, so you know that in the stomach you are going to see formation of HCl by your parietal cells, right? So for example, if a person is vomiting, it means he is also losing HCl, right? Is that right?
Yes, doctor.
Because you do not have any way to further cross this point, simply because it's hypertrophic, it's atretic in a sense, you can say. Okay, so what happens if I am losing acids? We will be seeing metabolic acidosis in the body, right?
Yeah.
Metabolic acidosis or alkalosis?
Alkalosis.
Alkalosis, yes. Look, you guys are sleeping. Alkalosis. We are going to see metabolic alkalosis, and there will be hypochloremic metabolic alkalosis, because along with H, the Cl is also lost. So can I say it would be hypochloremic metabolic alkalosis?
Yeah.
Okay. So, okay, and what's the treatment option? Just cut off this part, this muscular part, right? That is pyloromyotomy, right? Pyloromyotomy. Myo for your muscle and tomy for cutting. So pyloromyotomy. Just cut this part simply. Is that right?
Yeah.
Okay. So, yes, Dr. Reno, please, can you just give us an overview? Pyloric stenosis. Hello, Dr. Reno. Dr. Al Futures. Guys, you guys are going to see an MCQs on pyloric stenosis and NBMEs. I'm just telling you guys. And if you know this information, you can easily answer your MC. Hello. No one? Dr. Zainab, our last hope.
Hello.
Okay.
Yes.
Mm-hmm.
Yes, can you just give us an overview on pyloric stenosis so that we can just move forward then?
Okay. In pyloric stenosis, the pylorus of the stomach hypertrophy,
Okay, yes.
and the contents builds up behind that obstruction, and
Okay,
it lead to projectile vomiting. And it
yes.
is commonly seen in firstborns and also macrolide like erythromycin, azithromycin.
Okay,
And we lose protons or hydrogen in this condition, so it leads to metabolic alkalosis. And
yes.
also we lose chlorine, so we can see hypochloremic metabolic alkalosis.
Yes. And another thing, guys, you are also going to see hypokalemia. Okay, so simply you can also think of that if I am losing the volume, right? So we are going to see activation of your RAS system, right? If you are vomiting and I am losing volume, if I am losing volume, what happens to your RAS system, guys?
RAS system increase.
Activated. And what's the function of aldosterone? Aldosterone is going to secrete your H plus and your K plus, right? That's the role of your aldosterone. Is that right?
Yeah.
Okay. So if I am losing H plus, so again we are going to see metabolic alkalosis. And if I am losing K, I would be losing K plus as well. So it would be hypochloremic metabolic alkalosis. Is that right?
Yeah.
Yes.
Okay. So can you just revise this concept so that we can move forward further? Our last topic of embryology.
Yes, and so when we are vomiting, we are losing volume, and RAS system can be activated.
Okay.
So when RAS system aldosterone is increased, and aldosterone promotes hydrogens and potassium excretions, so we can see this
Okay.
is hypokalemic hypochloremic metabolic alkalosis.
Yes. And what about that olive-like mass?
Yes, and it is palpable like olive-like mass on palpation on epigastric regions, and treatment is surgical incision.
Okay, surgical myotomy. Anyone else who is going to revise this same topic, then we are going to move. It's very like high yield. That's why I just want to revise it again. Yes.
Can I go on, Doc? Hello?
Yes. Yes. Sure. Sure.
Yeah. Pyloric stenosis is due to the muscular hypertrophy. So where we're gonna see the olive-shaped mass in the second part of the duodenum. So what we're gonna see here is like we're gonna get the projectile vomiting because of the amount of the secretions takes place in the stomach,
Yes.
and it usually presents in the first male bonds
Yes.
and mother who exposed to the macrolides.
Okay. Perfect.
And in this patient, we're gonna see metabolic alkalosis. So where
Yes.
we're gonna see like hypochloremia, and because of the RAS system, we're gonna see the decreased hypokalemia as well.
Yes. Okay. Okay. So our last topic, that is pancreatic anomalies, right? Hello. Hello. Can you guys hear me?
Yes, doc.
Okay.
Yeah.
So this is your duodenum, right? Okay. Let's suppose this is your duodenum, and your pancreas basically sits here like a leaf-like structure, right? So this is your pancreas, right? So you have different part of your pancreas. For example, this is the head of your pancreas, right? This is the body of your pancreas, the isthmus, the body, and the tail, right? And this part is basically known as, yes, uncinate process, right? So, like embryologically, what happens? This uncinate part, like it do not build up like that. You have, like, for example, your biliary tree, right? Okay, so you're going to see two outgrowth, that is posterior outgrowth and anterior outgrowth, right? So this anterior outgrowth is going to move around, like for example, this part initially like forms here, right? So with time, what happens? It's going to revolve around your duodenum, and ultimately it's going to join this part, okay? And you're going to see the mature pancreas with head and uncinate process, right? So this basically arises from your ventral bud. So you're going to see two outgrowth, your ventral outgrowth or ventral bud, or your posterior outgrowth or posterior bud, right? So it means that ventral bud is going to revolve like that. It's going to move around your duodenum, and it's going to connect with your dorsal or your posterior bud, and ultimately it's going to result, the ventral is going to result in formation of the uncinate process in the head once they fuses, right? So sometimes what happens, you can have for example, if this rotation do not take place normally, and what happens, for example, if we have for example, if it's revolving around the duodenum, and what if it surrounds all of your duodenum, right? What if during this revolution process, what if this ventral bud surrounds your duodenum, and it grows and grows and grows, and ultimately it constricted your, for example, if it grows in such a way that it constricts your duodenum, right? This can happen, right? Hello, can you guys are you guys understanding what am I saying?
Yes. Yes.
Okay, like the ventral bud is going to revolve around your duodenum, and it's going to join with the posterior bud, ultimately giving rise to the mature or the normal pancreas. So what happens during this revolution process? Sometimes what happens, it just revolve around your duodenum, and it just closes off the lumen like that, right? So this condition is basically known as annular pancreas. What is the annular? Annular simply mean ring, right? So it would be a ring of your pancreas that is surrounding your duodenum. It encircles your duodenum. For example, if you have a lot of this tissue and it constricts the duodenum, what happens? Again, you can see same condition as atresia, right? As duodenal atresia, right? Is that right?
Yes.
if I'm just wrapping around the pancreatic tissue around the duodenum and
Thank you
it's
so much.
constricting
Thank
the
you.
lumen, so it can
Appreciate it.
become atretic. It would just, your duodenum can end into a blind tube if I'm constricting it. I'm not passing the things forward, right? I've constricted it. Simple. So it's same as duodenal atresia. Again, you're going to see vomiting. That would be bilious vomiting because here already the things are drained. Okay, so you are going to see bilious vomiting in this condition as well, and this is basically known as annular pancreas, right? Annular, simply annular stand for, the word annular stand for ring. So it's like just like a ring, it's surrounding your duodenum. Simply, it's constricting your duodenum. It's annular pancreas. And sometimes what happens, this ventral bud do not move back and it stay in the same position here. Like, for example, if the ventral and dorsal bud do not fuses, and if it remained in their location, so it's also a possibility which can happen. So this condition is known as pancreatic divism. So as the name indicate, like your divided pancreas. Divided pancreas mean that your ventral and your dorsal bud never fuses in order to form your mature or your normal pancreas, right? So pancreatic divism is also another pathology which can happen during the development of your pancreas. So what happens, what would be the complication of divism? Simply you can think of that, for example, if I have abnormal anatomy of my pancreas, right? It's abnormal. If they aren't fusing with one another, it means it's abnormal. So all of the ductal systems are going to be abnormal inside your pancreas, and there is increased chances of pancreatitis. So what is pancreatitis? For example, if all of the enzymes which normally your pancreas make, for example, if they are activated within the pancreas, you guys know it, like they make amylase, they make proteases, right? So it would just eat up all of your pancreas itself. For example, if the enzymes are activated within the pancreas, it can eat your pancreas, which is acute pancreatitis. Simple. Why? Because the anatomy is disrupted. There is increased likeliness of these enzymes to be activated within your pancreas, leading to
Hello.
pancreatic acute pancreatitis, right? So let me repeat it again. Pancreatic anomalies are of two kinds: your annular pancreas, for example, if the ventral bud encircles your
Oh, okay. I
duodenum,
see.
you're going to see bilious vomiting. It's associated again with your Down
Mm-hmm.
syndrome. You can just relate it with your duodenal atresia, right? The duodenal atresia was also associated with Down syndrome, right? Pancreatic divism, if the ventral and dorsal bud never come close to
Yeah.
one another, or if they never fuse with one
Okay.
another.
So it's
Okay,
on its
you have
way and it's
disrupted
going
anatomy
to
of
be
your
addressed
pancreas, so there is increased chances of acute pancreatitis, or in other words, I can say there are increased chances of these
yeah.
enzymes to
Okay,
get
perfect.
activated within the pancreas, giving
Perfect.
you pancreatitis, right?
All right, you too. Thank you.
Is that right?
Bye.
Yeah.
Yes.
Okay. So this was all about the embryology. So we are done with the today's lecture. Tomorrow we'll be finishing off the anatomy, and then we'll be starting the pathology section, right? So you guys can just practice your MCQs from anatomy. You guys might already have done, and then guys get prepared for your next NBME, right?
So when it is next NBME approximate is
Okay, so we are going to finish off these two systems. That is your GIT and your next repro. It would be like done in within 7 days, right? 7 to 8 days. So after that, we are going to take our next NBME
okay, so after completing GI will we have
and reproduct. Yes, we'll be having next NBME then.
okay, no, like in between small test
Yes,
or
you guys.
directly NBME.
Yes, no, you guys will be having your normal assessments in at the end of your GI, but after we completed the both of these systems, then we are going to take NBME, right?
Okay.
Okay. So thank you guys.
Thank you, sir.
Thank you. Bye bye.
Thank you, doctor.